Welcome to a PeDRA publication presentation. This presentation is an overview of a peer-reviewed study and is not a substitute for medical advice, diagnosis, or treatment. Any decisions related to medical care should be made in consultation with a qualified healthcare provider.
Hello everyone, my name is Angel Pagan, and today I would like to discuss our clinical research study titled Dupilumab Improves Clinical Scores in Children and Adolescents with Moderate to Severe Atopic Dermatitis, a real-world single-center study. Atopic dermatitis, or AD, is the most common inflammatory skin disease in children, with a prevalence of up to 17% in some studies in the United States. This prevalence also has been shown to vary by race and ethnicity. Its clinical signs and symptoms are chronic pruritus, or a persistent itch, and erythematous scaly patches. Despite more and more studies showing a worldwide increase in the incidence of pediatric AD, the development of effective long-term treatments has been slow. Dupilumab, which is a systemic immunotherapy or a biologic therapy, has proven safe and effective in extensive clinical trials in children and adolescents with AD. However, comprehensive real-world studies in the pediatric AD population are still needed. In this figure, we can observe the progression of the atopic march over the years, where infants often develop atopic dermatitis first, followed by IgE-mediated food allergies, and followed by allergic asthma and allergic rhinitis later in life. Unfortunately, for patients with atopic dermatitis, the burden of the disease extends well beyond the skin manifestations, including sleep disturbances, symptoms of depression and anxiety, among others. Many studies have also shown a well-established association between atopic dermatitis and attention deficit and hyperactivity disorder, also known as ADHD. In addition, a growing body of evidence is showing comorbidities with cardiometabolic diseases, such as arterial hypertension, congestive heart disease, and others. We must emphasize that atopic dermatitis is the most common inflammatory skin disease in pediatric patients in the US, with studies showing up to 17% of children and up to 16% of adolescents experiencing symptoms of the condition at some point in their life. Additionally, this prevalence has been shown to vary by both race and ethnicity. As for example, we can see a prevalence of up to 10% in Hispanic and Latin American children, 17% in white and European American children, and up to 19% of Black of African American children. Some recent studies have suggested that both Black or African American and Hispanic Latin American children with the condition may show more severe symptoms at disease presentation and an increased prevalence of emergency room visits for their condition. In our study, we have summarized the previous literature that have included pediatric patients treated with dupilumab for their atopic dermatitis in the real-world clinical practice setting. As we can see, some studies are limited by the small number of patients included, and others were limited by the data assessed within their study. For example, data such as the severity of the disease prior to treatment and the data explaining how the clinical improvements were measured afterwards. This clinical improvement is often measured by dermatologists with three disease severity measures, which are the BSA, or body surface area, EASI score, or eczema area and severity index, and the IGA score, which is the Investigator Global Assessment. These clinical scores are used by dermatologists to accurately measure the severity of the disease as well as the improvement after immunotherapy, as it is the case of dupilumab. In the present study, we aim to characterize the real world and the long-term treatment responses and the adverse event profiles of children and adolescents that were treated with dupilumab for their AD. We also aim to investigate the role that age, race, and ethnicity may play in the response to treatment in these patients. Our central hypothesis for this study was based on the fact that since Th2 cell upregulation is central to the disease, and recent studies have shown varying Th polarization in other axes such as Th1 and Th17 in different age groups. Throughout our research, our long-term goal has been to disseminate knowledge about the available treatments for pediatric AD at the clinical level that can further reduce the burden of AD in the affected families. The methods of our study are summarized in this slide, where we reviewed the electronic medical records of all patients with moderate to severe AD, starting Dupilumab at less than 18 years of age through this time period. The data collected included baseline demographics, as well as the AD clinical scores, BSA, EC, and IGA, as well as safety data. We will now summarize the findings of our study. In this table, we summarize the number of patients receiving other treatments for their atopic dermatitis. We can observe that the prevalence of systemic treatments in our cohort was very high, with almost half of patients receiving a form of systemic treatment for their disease at baseline. These systemic treatments may include prednisone, cyclosporine, and methotrexate. However, we can see that after treatment with dupilumab, the number of total systemic treatments was down to 0, signifying adequate control of the signs and symptoms of atopic dermatitis. Additionally, we conducted a detailed chart review of baseline demographics for our cohort, which includes sex, with more than 50% of the cohort represented by female patients, the age at atopic dermatitis onset, with a mean plus or minus standard deviation of 4 plus or minus 4.2 years. We can also observe that our cohort was diverse and included a variety of race and ethnicities within our study compared to prior real-world studies. In addition, the history of atopic conditions at baseline was very high, with up to 2/3 of patients in our cohort having one or more atopic comorbidity at baseline. These include allergic rhinitis, food allergies, asthma, eosinophilic esophagitis, among others. Further, we summarized the dupilumab therapy and the safety profile in this cohort. We observed that a treatment duration of 1.3 plus or minus 0.9 years and a dosing regimen with 300 milligrams every 2 weeks being the most common, with 59 out of 89 patients in our cohort. We observed a favorable safety profile in these patients, which is comparable to prior studies in clinical trials. In this table, we can observe the real-world effectiveness of dupilumab therapy in children and adolescents with atopic dermatitis in our study. We can note the different time points that we evaluated, and we can observe a long-term treatment response with patients who received dupilumab therapy for a year or more experience a mean BSA percent reduction of 89.1%, an EC percent reduction of 89.1%, and 100% of patients achieving 50% improvement or more in their EC score. All patients in our study who were treated for a year or more with dupilumab therapy experienced a 75% improvement or more in EC score, as well as an IGS score of 0 or 1. Overall, our findings were in line with results from prior clinical trials and prior limited real-world studies of dupilumab therapy in pediatric populations with AD. To our knowledge, this study was the first to, number one, extend the clinical observation period to 1 year or more. Number two, to include an ethnically diverse and representative population of pediatric patients with AD. And number three, consider the atopic comorbidities in the same cohort and report on their concomitant improvement with dupilumab. So now we can observe a complete visual summary of the findings of our study, where the main results can be summarized in 3 parts. First, a statistically significant decrease in the severity of atopic dermatitis across all three disease scores measured, BSA, EC, and IGA, that were all statistically significant. Second, we observed a high baseline prevalence of atopic comorbidities in this cohort, which subsequently correlated positively with BSA improvement. This means that patients with higher burden of atopic diseases at baseline showed the highest improvement in BSA reduction with dupilumab. Third, we were able to show in a real-world clinical practice setting that dupilumab is effective across sex, age, and race ethnicity in pediatric populations. And additionally, we noted a low adverse event profile in this diverse patient population.
Thank you so much for watching this PeDRA publication presentation. For more information, you can visit our website at www.pedraresearch.org.